All right, let's get straight into it. Welcome to this high-yield explainer on one of the absolute most rigorously tested, clinically uncompromising areas of neurocritical care, the brain death diagnostic algorithm. We're skipping the basics today. We are moving right into a strict peer-to-peer clinical breakdown. We're going to map out the absolute clinical thresholds, the intricate mechanisms of reflex dropouts, and the definitive guidelines for actually diagnosing brain death. Look, whether you're managing highly complex patients in the ICU or you're calibrating your knowledge for a perfect 280-plus board score, mastering these discrete management steps and identifying the diagnostic traps is totally non-negotiable.
Module 1, the clinical prerequisites. Before we even think about touching the patient to assess their reflexes, we absolutely must satisfy the prerequisite matrix. The cause of the coma? It has to be known, and it has to be irreversible. Now, what's really crucial here is just how rigorously we have to exclude confounding factors. You simply cannot diagnose brain death in a patient whose physiology is being artificially suppressed. The core temperature has to be greater than 36 degrees Celsius, that's 96.8 degrees Fahrenheit. Systolic blood pressure has to be sitting at least 100 millimeters of mercury, and critically, we have to entirely rule out drug intoxication. We're specifically looking out for central nervous system depressants like opioids, which, as you know, cause profound respiratory depression, bradycardia, and meiosis. If there's a severe metabolic derangement or lingering paralytics in the system, testing simply can't proceed.
The reflex dropout, absent brainstem arcs. Once those strict prerequisites are met, we move directly to the clinical examination. Clinical brain death requires the absolute irreversible dropout of all cranial nerve and brainstem reflexes. We are talking about a completely absent motor response to central pain and literally zero pupillary, oculocephalic, oculovestibular, corneal, gag, or cough reflexes. But it doesn't stop there. We also have to test the vagal nucleus. Normally, if you administer atropine, it accelerates the heart rate by blocking vagal tone, right? Well, in brain death, vagal control from the brainstem is entirely lost. That means the heart rate becomes completely invariant. If you give atropine and that heart rate accelerates even a little bit, the brainstem is still functioning.
Now pay close attention to this next point, because it's a massive trap on the wards and on advanced board exams. Deep tendon reflexes may actually still be present. Think back to your neuroanatomy. The spinal cord can continue functioning completely independently of a deceased brain and brainstem. So you might actually elicit a patellar reflex or even observe spontaneous spinal movements. But because those specific movements don't require any brainstem integration, their presence does absolutely nothing to invalidate a diagnosis of brain death. Do not let that clinical finding sway your diagnosis.
Module 2, the apnea mandate. If the clinical exam shows total brainstem areflexia, we proceed to the ventilatory challenge. The apnea test is the definitive, strictly mandated clinical confirmation. First, we heavily pre-oxygenate the patient. Then, we completely disconnect them from the mechanical ventilator and observe them closely for 8 to 10 minutes. What are we looking for? Any spontaneous respiratory drive. The absolute biochemical threshold for confirming brain death requires zero respiratory efforts, and the final arterial PaCO2 must reach at least 60 millimeters of mercury, or at least 20 millimeters above the patient's baseline. Now, you might see some older texts mentioning a 50 threshold as an early marker of hypercarbia, but standard modern criteria demand pushing it to 60 to definitively prove that those medullary respiratory centers are gone.
So what happens if hemodynamic instability aborts the apnea test? This is the high-stakes clinical scenario. What happens when the test fails? Not because the patient takes a breath, but because their body physically cannot tolerate the stress of the test. The apnea test has to be immediately aborted if the patient becomes hemodynamically unstable. Specifically, if their systolic blood pressure drops below 90 millimeters of mercury, or if their oxygen saturation drops significantly before you ever reach that hypercarbic PaCO2 threshold. You absolutely cannot just write out a crashing blood pressure in an attempt to finish the test.
Looking directly at the National Board of Medical Examiner standards really reveals the strict legal and ethical framework we have to operate within. Brain death constitutes both legal and clinical death. Once it's confirmed, mechanical ventilation can be withdrawn without the family's permission. However, when the diagnosis is uncertain, like when an apnea test has to be aborted due to instability, you simply haven't met the legal definition. You can't just declare death and withdraw life support. You've got to adjust your diagnostic strategy immediately.
Module 3, the ancillary shift. If the primary apnea test is inconclusive, or maybe it can't be performed because the patient is a chronic CO2 retainer, or it's aborted due to that hemodynamic instability we just talked about, ancillary testing becomes unequivocally mandated. The absolute confirmatory standards here are either a cerebral angiography demonstrating a complete absence of structural blood flow to the brain, or a radionuclide brain scan showing zero uptake, which we clinically call the hollow skull sign. An EEG showing no electrical activity can also be used, though it's generally a bit less preferred due to sensitivity issues and all the artifact interference you get in a busy ICU.
Clinical variance box. Let's make sure we can definitively differentiate brain death from a persistent vegetative state, or PVS. The clinical variance here is stark. Brain death is the total, irreversible loss of all brain and brainstem function. It literally equates to legal death. PVS, on the other hand, is the loss of cortical function only. These patients absolutely retain their brainstem reflexes. They've got preserved gag and corneal reflexes, and crucially, they have spontaneous respiratory drive. A patient in a persistent vegetative state is legally alive. Withdrawal of support requires entirely different ethical and legal pathways, like advanced directives or proxy consent.
The master case, patient profile blueprint. All right, let's test some deep integration with a master case structural blueprint, calibrated specifically for top-tier clinical reasoning. Here's the profile. We've got a 25-year-old trauma patient with a Glasgow Coma scale of 3. Prerequisite vitals are met, and they have completely absent brainstem reflexes. You initiate the apnea test. But 4 minutes in, the patient's blood pressure abruptly drops to 75/40. You do the right thing, you follow protocol, and you abort the test. The arterial blood gas drawn at the exact moment of the abort reveals a PaCO2 of 52 millimeters of mercury.
The option matrix. Next best step? You are asked for the immediate next best step in management. Here is your option matrix, simulating actual high-stakes exam conditions. A. Diagnose brain death. B. Repeat the apnea test immediately. C. Perform cerebral angiography. D. Administer naloxone. E. Maintain current support and wait. Think carefully about the physiological state of this patient and the rigid diagnostic algorithm we just reviewed.
Assessment execution, option C. Let's exhaustively break this down. The correct answer is option C, perform cerebral angiography. Here is exactly why the other options are fatal clinical errors. Option A is incorrect. That PaCO2 of 52 is a deliberate diagnostic trap. Even though it crossed 50, it didn't hit the definitive 60 threshold. But far more importantly, the hemodynamic crash physically invalidates the test entirely. Option B is incorrect because the patient is currently sitting at a blood pressure of 75/40. They literally cannot tolerate a repeated physiological stress test right now. Option D, naloxone, is incorrect because standard prerequisites, which include a negative toxicology screen, were already met before we even initiated the apnea test. Option E is incorrect because maintaining support without a definitive diagnosis is inappropriate resource allocation and completely avoids the mandated algorithm. The aborted test is totally non-diagnostic, outright forcing the selection of an ancillary test like angiography to prove the absence of cerebral blood flow.
Final integration. As we wrap up this explainer, I really want to leave you with this final thought. The algorithm for diagnosing brain death allows for absolutely zero diagnostic ambiguity. Are you prepared to differentiate a twitching, autonomous spinal reflex from true brainstem function under the intense pressure of the ICU? Are you ready to confidently shift to ancillary testing the moment physiology fails you mid-test? Master this framework, respect the absolute clinical thresholds, and you will navigate these profound clinical moments with total precision. Keep reviewing the material and keep your clinical logic razor sharp.